In recent years, with a rising proportion of older people in the population, many with long-term medical conditions, older people have accounted for an ever-rising level of emergency hospital admissions. The NHS is now experiencing more than 2 million unplanned hospital admissions each year for people over 65, accounting for 68% of hospital emergency bed days and the use of more than 51,000 acute beds at any one time. The issue has made headlines and more generally become the focus of media attention.
There's often an assumption in the media that potentially large numbers of frail older people are turning up at and being admitted to hospital unnecessarily when they don't really need the services provided there.
Supported by the NIHR Research for Patient Benefit Programme, a team of researchers at Birmingham University has carried out a study into the issue across 3 case study sites.
We wanted to look at what causes the emergency admission of older people and how appropriate are those hospital admissions. And we wanted to understand it from the point of view of frontline staff who work with those issues day in and day out. And especially we wanted to understand it from the point of view of older people, their experience of hospital admission, what had caused it, what had happened in the run-up to admission, was the hospital admission needed from their point of view, and what might have been done differently. We also tried to get some data from those people's hospital doctors and their GPs so that we could compare and contrast those views. Alongside that, we did a number of interviews in our 3 case studies with frontline health and social care staff to try and understand some of the services that were available locally and some of the responses that have been developed over time to these issues. And we did some focus groups with those professionals with vignettes or case studies based on some of the true stories from our interviews with older people.
In addition to the report, the research material is being applied to a good practice guide, which is being sent to every hospital trust in the country.
In the process, we're supported by a series of national and local organisations who are helping us to disseminate the research. So as well as being a research study in its own right, hopefully this is something that can have a policy and a practice impact because of that national guide and because of the support we've got from national policy partners.
A key finding of the research was that most of the older people who were the subject of the study were admitted appropriately.
The bulk of our older people and their professionals feel that hospital was the right place for them. Those admissions were primarily appropriate.
Across the study, reasons for admission were found to be far from trivial.
I've been in hospital 13 times. The first time was when I was rushed from the doctors to Brighton thinking I had a heart attack.
One of the problems that she had about 6 years ago is that she turned over in bed and broke a hip. And there have been several hospital appointments, hospital admissions, in which, because of falls in the last few years.
She'd passed out on the dining table while eating, which is very surprising for us. Never had that done before. She vomited, passed her bodily fluids, and her tongue was to the one side, so I immediately thought she'd had a stroke.
Only 9 out of 104 older people felt that hospital was not the right place for them, and none of the GPs or hospital doctors who took part felt that these admissions were inappropriate. Sometimes, alarmingly, many older people delayed seeking help.
We also found a number of older people who, to us, seemed very unwell or in quite a lot of pain, who delayed seeking help, either hoping it would go away or that they could make it through overnight, for example, if something happened out of hours, or waiting to talk to a family member or a friend before they sought assistance. They'd clearly read and taken on board some of the media accounts that you hear, and they describe themselves as not wanting to be a burden on services.
I did feel uncomfortable because they said, "Oh, how many times you been in now?" I mean, not that they didn't treat me, I was being treated, and that, but I just felt uncomfortable about it all. For the amount of times I keep going in hospital, I was beginning to feel they thought I was a hypochondriac because I kept going in, and that made me feel worse. But in the end, I feel as though I don't want to go to the hospital. Even if I was dying, I don't think I want to go to the hospital.
Especially the wartime generation who remember the inception of the NHS, you don't want to keep people in here like me, doctor. You know, I don't want to be taking up a bed, they'll say. I don't want to be too much trouble. So they often will feel an obligation, and they'll often say, slightly pulling your leg, but slightly aware of the realities, I know what you want to do, doctor, you want my bed, don't you? So I think they do feel that sense of obligation quite frequently.
Although people were in hospital appropriately, there might still be some scope for longer-term preventative approaches.
When they're at home, and often with long-term medical problems and slipping into some kind of crisis, they could have been supported earlier. There could have been an intervention earlier before they ended up in the emergency department, in the acute medical unit.
I think there is an opportunity to look at the time before hospital and actually going back a few months before hospital and seeing which of these deteriorations are predictable.
The research has revealed a strong consensus that hospital often remains the default destination.
A lot of older people have a number of comorbidities, so they're under their GP and they're under lots of different specialists, as well as seeing lots of other members of the multidisciplinary team in the community as well. And I think a lot become very confused by that, and there are so many people involved in their care that when something starts to go wrong, if they start to become unwell or if they're needing more support, they're not sure which person to turn to. And unfortunately at that point, I think a lot will then turn to A&E. It's the place that comes into their mind, and they feel that that's the place that they'll receive some immediate support.
More generally, poor communication was identified as an issue.
I found a lack of communication between different departments and everything, and they say, oh, we sent the letter and no one's, we didn't receive it. You know, it's really, nobody chases anything up.
They did feel that a more proactive, more community-orientated response might help to divert some people away from hospital.
Some of these patients are perhaps running into problems, but they're not acutely unwell enough to come into hospital. And there are things that we can access and facilitate in the community or within our day hospital.
The situation is exacerbated by the misconception that hospitals are inherently safe places for older people to be.
People in the community often feel that they have 24-hour care, they're watched all the time, and they think that they're safe as a result, and that's quite a barrier. We get that from professionals as well as carers and relatives.
If you languish in hospital, you can be exposed to infection, you can lose confidence, it can be harder to go home, you may fall over, you may become acutely confused, delirious. It's the idea that somehow hospital is safe and home is dangerous. It's not a zero-sum game.
The research identified the scope for more proactive initial approaches when older people first contact services.
For one person on his own to decide, does this person you're looking after need to go to hospital or not, would be difficult.
If you could have community care where you could phone up someone and say, you know, this is how, and they could come and see you and say, well, if you do this or we do that, you might not have to go into hospital.
There has to be a credible single point of access 7 days a week when things are going wrong. Whether it's the home care worker, whether it's the care home worker, whether it's the community nurse, the GP, the older person or their carer, when things are starting to go wrong, when they're struggling, they need someone to phone that will respond quickly, will be on the scene quickly and provide that kind of wraparound service that might keep them at home. Because at the moment, people go where the lights are on, which is the A&E department, and once they're in with a 4-hour wait, they'll inevitably get sucked into a bed.
It would be good to have an organisation where there were a team of people, a specific job description which covers potential emergency admissions at home in the community. That's really what needs to be done.
A small number of people felt that an earlier hospital stay or assessment might have resolved an underlying problem sooner.
Perhaps a more proactive response from a GP, perhaps an earlier test or a hospital stay where there could have been scope to clear up an underlying health and problem once and for all without it re-emerging later on and contributing to the particular admission that we were studying.
Managing them well when they come here, getting them properly back on their feet when they go to a step-down service has long-term benefits. And we need to remember that it's one window to try and get things right.
In this trust alone, there were 28,000 A&E attendances last year with patients over the age of 75. What I can do is to try, when I'm there, to work with the A&E teams in helping to train them, to give the junior doctors in particular more confidence and more expertise in assessing older patients living with frailty, older patients living with dementia, groups of patients that they find quite difficult if they've not done a lot of that type of work before.
A number of older people in the study were in contact with their GP or contacted the ambulance service. If we are to develop a more preventative approach, working with GPs and paramedics could be a good place to start.
I think with an elderly person over 90, if there's any doubt that there may be problems, internal problems or broken bones or whatever, I think the right thing to do is to call the paramedics, get her assessed by the paramedics, and if they believe that she should go and be checked out in hospital, then that's the best place for her.
And of course we mustn't forget the ambulance trust. It's the ambulances that respond to people in their own homes. And in some parts of the country, good shared working with the ambulance trust mean a lot of these people, for instance, if they've fallen over, can be diverted to an alternative assessment and away from the hospital. Most older people pitching up at the front door of hospitals have not been referred by their GP or out of hours. They're defaulting straight to the ambulance or emergency care system. When they do arrive, it's often hard to piece together what's been happening because we don't have that GP referral letter, we don't have access to the notes. They often don't have a care plan that everybody's signed up to.
People taking part on behalf of family members with dementia felt that some health services are not set up to work well with people with dementia and that social care support is currently insufficient.
One big group we see are people with dementia who come into hospital because they need a safe haven, they need a place to go. So quite often they're found by neighbours wandering in the street or at night and distressed. And there is no community placement, so they come into hospital. That often feels totally inappropriate. People perceive, both carers, relatives, professionals, that we are a safe place for people with dementia, but it doesn't feel like that at all. We are taking people away from their familiar environments where they're working on old memory. They know everything within their homes. They know every foothold, every step, and we're bringing them into a large, busy, hostile, noisy, strange environment where our focus is really on treating people who are acutely medically ill.
So there's two things. There's the one where you can actually see when somebody passes out, vomits, does all the things that someone that you think is having possibly a stroke or being unwell, maybe a heart attack or something, and we saw that with Mum, and each time she was admitted, that was the only time we called her because she was having palpitations or having a vomit or passing out, and so we called it. But there were other times when she didn't do any of that. She didn't have any palpitations, she didn't have heart problems, she didn't pass out. She was just in a mental state where she was screaming, shouting, and there was just me and my wife. And all we could do was keep quiet and let her get on with it.
In many cases, it was found that there was simply an absence of social care.
It's the care that is key to keeping people at home.
We shouldn't be doing home at hospital, and there's far too many people staying too long for things that should be provided outside the building.
The large majority of the problem comes from the softer sides, the social sides that impact significantly on an individual's health. And as a doctor, I struggle to influence that. And we see more and more that people that could have had more support, more occupational therapy, more caring supports, more help with mobility, more help with food, simply just eating, results when that's deficient in them becoming unwell, becoming dehydrated, becoming malnourished, becoming weak, becoming vulnerable, and increasing their risk of falls, increasing their risk of being at harm. And ultimately that makes them more vulnerable and more prone to having a urinary tract infection, developing a pneumonia, having a fall, breaking a hip.
With ever-increasing demands placed upon social care, a widely held belief expressed through the research was that social care was simply underfunded.
Social care has been cut savagely and we don't have enough capacity in social care.
There needs to be much more investment in terms of how we look after our elderly. We either do it ourselves or we have to pay for it.
Overall, this study argues that older people have a crucial role to play in understanding the issues at stake regarding emergency admissions.
It's often older people who have a long-term overview of what's happened to them as their health has deteriorated, as they've sought help from different services, what has or hasn't happened next, what happened on the day when their health really started to deteriorate and they ended up in hospital, and indeed some insights into the hospital stay itself and what happened next. The professionals, no matter how well trained or how well educated, only ever see the person after they walk in through the front door. So they can comment on what happened on the day or when they first met the patient. They haven't got that sense of how life has changed and what has happened over time. And actually, that's a vital source of expertise that we neglect at our peril.
This need to listen more to the experiences of older people is supported by a more general opinion amongst professionals to make the service more patient-focused as a whole.
What I think we're not getting right is making sure that that service, first of all, fits around the patient. I think it's quite hospital-focused rather than patient-focused.
I think sometimes in our rush to save money, to prevent admissions, to create beds, even well-meaning, caring health professionals can medicalise and proceduralise the process. And I think we've got a long way to go making care and support more personalised for older people.